My name is Michael Pulla, and today I'm going to be discussing with you soft tissue masses and skin lesions of the lower extremity. I have no conflicts of interest to disclose. So we're going to define some of the terminology for this topic. We're going to discuss how to perform an examination of these two things. We're going to review a few of the more common diagnoses of skin lesions and soft tissue masses. We're going to talk about how to diagnose and how to treat these. So starting with terminology here, we're talking about a tumor generalized as any enlargement of tissue, edematous, hypertrophic, or neoplastic. There's irreversible and there's reversible terminology to be familiar with. Irreversible, anaplasia, neoplasia, desmoplasia. When we're talking about reversible types, there's hyperplasia, metaplasia, dysplasia. We look at this chart here in regards to skin lesions. Normal cells that can give rise to hyperplasia when they're chronically inflamed. These are kind of precursors to neoplasia. We talk about a localized type of neoplasia, intraepithelial. This is kind of that pre-cancer, pre-malignancy. Move on to something that's more invasive, causing cancer, and it starts to cause microinvasion and metastases. So we talk about something being benign. We know it's well differentiated, it can be encapsulated, and it does not metastasize. Something is malignant on the other end. It invades surrounding tissues. It does have metastases, and it shows poor cell differentiation. Carcinoma and sarcoma. The difference is carcinoma shows that it is of epithelial origin and it metastasizes via the lymphatics, while on the other end, sarcoma is of mesenchymal origin and it metastasizes via the blood. In regards to these metastases, the liver and the lung are the most common sites of metastases, but in regards to bone metastases, they're most commonly from prostate and breast cancer, and primary metastases to the skin are quite rare. What are the treatments and how do we define these? Well, there's palliative treatment where we're really not resecting anything surgically, but we're getting radiation and chemotherapy to try to shrink that tumor. Adjunctive is surgical resection followed by chemotherapy after, and neoadjunctive would be chemotherapy before the surgical resection. We're obtaining the patient's history. Things we want to discuss are, do they have prior cancer? Do they have current cancer? What is the diagnosis? What has the treatment been? Have they had a family history? Anybody in the family have cancer prior? How old were they? What was the type? Do they smoke? Are there any other risk factors, such as a chemical exposure? On our review of systems, we want to know several things. Have they lost any weight in a short period of time? Do they have chronic cough, night sweats, changes in their normal routine? And regarding to the presenting symptoms themselves, where is it located? How long has this been going on? Is there pain associated with this? Has there been a rapid growth rate? Itching, discharge? Is the site ulcerate from time to time, close back up, have discharge? Was there any preceding trauma prior to this? Paresthesias, warmth, any of these factors? So we're doing our dermatologic exam, things we're looking for. We're going to follow the ABCs here. Asymmetry, borders. Are there well-defined borders? Does the lesion look asymmetrical? The color of the lesion. Certain differential diagnoses can be placed based on the color of the actual site. What is the diameter that we see of it? Larger lesions can sometimes be more concerning. Diascopy I have in here too. It's the blanchability of the lesion that can tell us something. Elevation, is this something that's elevated beyond the skin? Is it flush with the skin itself? Fragility, what that means is, does it bleed readily when we touch it? Lymphadenopathy, is there associated lymphadenopathy in the region or the extremity associated with this? So the first of these to look at is basal cell carcinoma. It is the most common malignancy of the skin. Oftentimes we see it on the upper face. It is a hair germ cell differentiation. It has the telltale signs of being nodular, kind of that rolled, pearly rim. Sometimes it can appear as a papule with prominent vessels. It does ulcerate and bleed from time to time, but it is rare to metastasize. So now squamous cell carcinoma, this is the second most common malignancy of the skin. See this more on the lower face during sun-exposed areas. Again, it is rare to metastasize. We start to see this as a firm papule, but it has scaling indurated ulceration points. We know that very rarely Verruca can actually turn into a form of squamous cell carcinoma itself, very slow growing, locally destructive, but also rare to metastasize. Marjolain's ulcer, this is something that's rare, but it is an aggressive form of squamous cell carcinoma. It has a higher metastases rate. This comes from our long-standing open wounds, sites of chronic irritation, often associated with a burn scar. We can see it with venous stasis ulcerations too and trauma, but they are common to the lower extremity. It does take a long time for these to develop, though. The average latency I have here is about 29 years. So it does take quite a while for this ulceration to transform to a malignant state. Sometimes there's associated lymphadenopathy, and it can recur. And oftentimes the treatment for this is a wide excision with either grafting or sometimes amputation. So now moving on to melanoma, if you wanted to have the correct term for this, it would actually be melanocarcinoma, as we talked about before with the epithelial origin. So we see this in fair-skinned individuals. They're more susceptible to that ultraviolet radiation. It's the 5th most common form of cancer overall, and it has separate growth phase, the radial and the vertical phase. Vertical phase being that more invasive phase as we start to get further into tissue. Go over the different types of melanoma we see. There's a nodular subtype of melanoma. This is more malignant as it does not have a radial phase and it can ulcerate. Superficial is the most common, and this can extend out horizontally several layers before it reaches a vertical phase. Lentigo maligna, this is the slowest growing form. There's a long radial phase. Acrolentiginous, this is the one we're going to see more commonly. It can be aggressive. We see it on the hands, we see it on the feet, and associated with the nail matrix. There is a radial phase, but it is short. This is what we can see as far as subungual melanoma as well. We start to see what's called that Hutchinson sign when it invades the eponychium. Amelanotic melanoma is something that's poorly differentiated melanoma rather than a variant. When we look in grading these, we'll get a path report back. The pathologist will measure the depth of it, and there's varying prognosis based on how far it has invaded. Once we start to get into the subcutaneous tissue and invasion of further underlying structures, we'll have more problems. So we look at our survival rate, and as discussed with the depth of invasion, if something is caught early on, obviously we know that this is going to spread less. We'll have a better chance of capturing that before it'll invade other tissues. Once our depth gets beyond 4 millimeters, there's a pretty stark 50% survival rate. So we're looking to biopsy a lesion. Why do we do this? Well, of course, we're trying to get a diagnosis, but we're also trying to find what those cells are from as far as an origin when we get the pathologist to look at it and give our path report back. We do these to see if something just looks abnormal, what it could be. If it has a peculiar growth rate, there's no healing within a wound within a certain margin of time if the wound care is optimized. Do we have a Hutchinson sign? Is there a stubborn lesion along the nail bed that we're not familiar with? Something is incisional versus excisional biopsy. Incisional, we're just taking a piece out of a larger lesion to try to biopsy it. Excisional, we're removing the entire lesion with elliptical incisions. If we have good margins, this will be curative. Punch biopsies can be incisional or excisional, depending on the size of the lesion and the size of the punch. If we have clean margins and have taken the whole lesion out with a punch biopsy, it'll be excisional. If a lesion is above the level of the skin and is pedunculated, sometimes you can use a shave biopsy. Would be the appropriate means for that. When you're creating a block to try to anesthetize the area, you don't want to inject directly into the site and give yourself a good block and good margins beyond that. When you're obtaining a specimen to diagnose, sometimes it's better to have a larger specimen for some inflammatory lesions associated with dermatitis, more so than with tumors. We're going to place these lesions either fresh or in formalin. When we're creating these defects, usually the cutoff for a biopsy is punch biopsy about 4 millimeters or greater. You're going to want to put a nylon suture across or your preferred choice of suture. So we're discussing surgery for these types of skin lesions. What do we do? You can have a destructive form or you can resect it and excise the lesion. So destruction, we do this only for benign lesions. A good example for this would be a verruca. Everyone's got their treatment of choice they do for a verruca once it gets to a point where surgically treated or invasive procedures are done. You can cauterize after curetting the lesion. You can use cryotherapy. You can excise the lesion if it's small enough. Many options. Talking about resecting something, in the case of malignancy, the options are wide excision, compartment resection, or even an amputation. Someone's described as a Mohs microsurgeon as an oncologist. They're usually doing a microscopic removal in very specific cosmetic places, such as the face. Oftentimes, some lesions, when they spread, they'll need a regional lymph node dissection by an oncologist to see how far things have spread, what the extent of the damage is. So say if we've obtained a diagnosis of melanoma, what are some of the guidelines and principles for resection of this? Well, they're all excised down to the subcutaneous level. Less than a millimeter, usually there's 2 centimeter margins with primary closure. Up to 4 millimeters, you can see a 3 centimeter margin, sometimes closed with a flap or graft. Greater than 4 millimeters, you're going to see even further margins of 5 centimeters. You're going to take further tissue out underlying the deep fascia. Lesions of the actual digit themselves, or with subungual melanoma that have spread, oftentimes this is going to require an amputation of the digit. So moving on now to soft tissue masses. What is quote-unquote soft tissue? Well, it's non-epithelial extraskeletal tissue. This would include muscle, fibrous tissue, nerves, vessels. How is this classified? Goes along classification of the World Health Organization. There's many different benign and malignant tissue tumors in the foot and the leg. Oftentimes these are more secondary to an outside force. They're reactive, inflammatory in nature from trauma, more so than an actual true primary neoplasm. The staging of these goes through the TNM category, the size, regional lymph node involvement, and metastases. On exam, what can we look for? Well, we look and see if something is large, small. What is the shape of it? Is it well circumscribed? Where is it located? This can tell us quite a bit if it's on the dorsum of the foot, the plantar aspect of the foot. Certain lesions have telltale locations that they are often at. What does the mass feel like? Is it itself really mobile? Is it very firm down to the underlying tissue? Does it hurt to touch? Is it painless to be manipulated? Is there any associated warmth? Are there any color changes or blanching of their overlying skin? It might tell you the depth to a degree. Is this something that has ulcerated in the past, closed up as well? Has there been any drainage from it? When we palpate the site, does it have a pulsatile nature to it? When we place light along it, is there any transillumination suggesting underlying fluid or cystic changes? Is there associated lymphadenopathy? I have in here plain film too, because oftentimes we go straight to an MRI to look at a soft tissue mass, but sometimes a plain film can show us stuff on occasion too. Where the mass is located, the density, is there any calcifications within the mass itself? Is there any involvement of the underlying osseous structures, creating a periosteal reaction or invasion to the underlying bone? Can we get some rough margins off of the plain film as well? So we're looking at benign soft tissue lesions of the foot, ankle region. Epidermal inclusion cyst comes here first. We look at that. That's something you're going to see after trauma, as the epidermis, the top layer of the skin, gets forced into that dermis and continues to multiply. It can wall itself off, create this subcutaneous type of nodule. Sometimes it does have discharge as it's extruding that extra keratin that it's building up in there. They can be asymptomatic, or oftentimes they can be symptomatic, either if they become infected or in a prominent area like the plantar skin under a weight-bearing surface. Lipoma is the most common soft tissue tumor in the body overall. A globule of fat will be walled off, separated by fibrous septa. Ganglion cyst, every podiatrist is very familiar with these. The most common soft tissue mass on the dorsal foot and ankle. Fluid-filled cysts, they can vary in size. They can sometimes get smaller, sometimes get bigger. They have a varying history, we'll hear from patients. These have a high recurrence rate. Oftentimes they're mobile, but sometimes they can be firm down, especially if they're coming off of a joint or an actual extensor tendon. The origin of these is actually myxoid degeneration of the connective tissue itself. Sometimes we'll see that when it comes back in a path report. Varying treatments for these: primary excision, aspiration, high recurrence rate as we discussed. So fibromas, as we talked about, with the most common mass being the ganglion on the dorsal foot, the fibroma is by and large the most common on the plantar foot. Very high recurrence rate, one of the most common enemies of the podiatrist here. So fibromatosis, true fibromatosis is an autosomal dominant trait. We talk about fibromatosis in the hand, has oftentimes associated with bad contractures. We don't see that quite as commonly in the foot itself. It's different phases of growth. The laterality can vary. Sometimes patients have this bilaterally, sometimes unilaterally, and the size can greatly vary. Sometimes the masses are quite subtle. You have to very deeply palpate to even find the subtle mass. Other times it's large enough to tent the skin along a very prominent fascial band. Treatments, we try to avoid surgery firsthand on these, going conservatively. We try to find orthotics that might put pressure away from the lesion, offload the site. Sometimes a good accommodative orthotic with a cutout. Varying topical medications, sometimes even intralesional injections that have been done to try to shrink these masses. Certain types of medications patients take orally can actually increase fibroblastic rates and cause these more commonly. When we're excising, there's various ways to create incisions planarly, different margins based on the size of the lesion. For these, to try to get less recurrence, bigger margins is often better. This creates the problem, though, of plantar scars. The plantar foot doesn't like scars, so we try to offload these as they heal to try to give a better scar. Varying types of scar treatment topically afterwards, whether it's vitamin E or any other type of topical that will help with the scar healing. So when discussing malignant soft tissue lesions, these have varying growth rates. Oftentimes they can compress the surrounding normal tissue, start to cause pain, but they can be painless as well. They create this type of pseudocapsule. They have extensions that pierce through. They can give rise to metastases, satellites. Sarcomas in general are quite rare. They're less than 1% of all malignancies, and the overall death rate of a foot sarcoma is just over 10%. And talking about the different types of malignant soft tissue lesions, a fibrous histiocytoma is the most common soft tissue sarcoma overall. It's located deep below the deep fascia. Oftentimes we don't find these until there's initial diagnosis of pain that's causing the presentation. The prognosis gets better when it's distal to the knee. You can see the varying survival rates here at 5 years. A liposarcoma, this is the second most common cause of a soft tissue sarcoma. It's also deep below the deep fascia. There's many different subtypes. So malignant soft tissue lesions of the foot and the ankle, most common one we're going to find is synovial sarcoma. These tend to be rather slower growing. We get a plain film we can see on the side here. Oftentimes that'll show up as far as increased radiodensity around the lesion itself. These are more seen as a predilection more in the rear foot, along the ankle, the heel, dorsal of the foot. Not to get confusing with terminology, but they can also be called carcinosarcomas due to the epithelial cells located within them. Oftentimes they can be painless. Sometimes they can be painful. Again, we talk about the calcifications we see on the x-ray here. They can be nodular as a singular mass themselves. They have a very high recurrence rate, and they can metastasize quite readily too. There's a varying survival rates, 5 and 10 years as we have listed here. So different types of biopsies for these soft tissue lesions. What are we going to do? There's fine needle biopsies, core needle biopsies. These would be closed type biopsies. So we're going to use fine needle aspiration. Sometimes we can do this under ultrasound to get a good view of the lesion as we're doing this. Core needle would be the higher gauge needle, trying to get a larger piece of that specimen for analysis for the pathologist. Open biopsies then, you look at something you can, again, similarly perform an incisional versus an excisional biopsy. Certain criteria based on the size, whether you want to excise that completely to start, or you want to take an incisional biopsy to find prior to your full resection. Something we always talk about is to culture what you biopsy and biopsy what you culture. So it's not a bad idea if you're confused on the actual specimen you're taking out, whether you should take a sample too and culture that, send that off to microbiology to further review if it's of an infectious origin, whether it be bacterial, fungal. So actual surgical principles of these types of masks, we're taking them out. One good principle is to always Treat every mass that you're taking out, whether it be a very common ganglion or fibroma, as it could be something concerning. You never know until you get that true pathological report back. So when you're looking at something, you want to be really careful with your tissue flaps. Try to raise as little flaps as possible. You want to make sure your hemostasis is very well maintained. You want to try to bovie off any bleeding vessels prior. Sometimes let the tourniquet down prior to closure, so you're making sure you're not creating any type of seeding vessels. When we do sanguinate these, you want to try to avoid sanguination over the lesion, especially if you have a cystic type lesion. You could lose the lesion. So we talked before about sometimes doing closed biopsies beforehand, the core needle biopsy, to get an accurate diagnosis when a lesion looks rather suspicious. Or even say if we take out a straightforward benign looking lesion but it comes back as malignant, well, oftentimes those will have to be re-excised to reduce that risk before any type of radiation or chemotherapy will be started. The rate of unplanned excision of soft tissue sarcomas in the extremities is about 40%. These will lead to recurrence, metastases, decreased survival, as you could imagine. The difference between if you actually have a planned wide resection with radiation therapy, there's about a less than 10% recurrence rate in lower extremity sarcoma. An unplanned resection has 32% recurrence rate, so quite a difference. We're excising these different types of terminology to talk about the actual resection. Our goal would be to eradicate the lesion, control any of these type of metastases, and actually salvage the limb. So an intracapsular excision, this is similar to debulking, removing the tumor within the pseudocapsule itself. It's a subtotal resection and it actually leaves behind disease itself. A marginal local excision would be to remove the lesion, dissect outside but close to the type of pseudocapsule. This may leave some satellite lesions or metastases behind. Wide local excision is a sharp dissection through all the tissue planes without exposing that capsule itself. It'll remove the tumor and the whole biopsy tract with a cuff of normal marginal tissue. Radical resection would be taking out the entire compartment with the neurovascular structures itself. So radiation therapy, do we see radiation therapy in the foot and ankle, and what are its repercussions? Well, radiation and wide excision is the same as radical excision in terms of the outcome and the prognosis. Radiation itself does tend to do more harm than good in the foot. Just a little amount of subcutaneous buffer that we have there can lead to disability through the actual skin sloughing, the atrophic skin that we can see, and arthrofibrosis itself. These are my sources for this lecture. This is my contact information. If you have any questions, please contact me. Otherwise, thank you very much for listening. Hello, my name is Michael Pulla, and I'm going to be discussing with you today chest x-ray interpretation. I have no conflicts of interest to disclose for this lecture. What we're going to be going over today is a brief review of the pulmonary anatomy, how to identify what a normal chest radiograph looks like, a review of some of the more common pathology, and understanding how this relates to us as podiatric surgeons. So to start with some brief anatomy, as we know, the pathway of the airway goes from the pharynx to the larynx of the voice box, then the trachea and the bronchi. The carina is the midpoint here. Right lung has 3 lobes, and the left has 2, with a cardiac notch along the medial border. The vasculature consists opposite of the rest of the body. The pulmonary trunk has 2 arteries carrying deoxygenated blood, and the veins return 4 with oxygenated blood back. Our mediastinum, separated into several compartments. The anterior consists of the lungs and the thyroid, the middle with the heart, trachea, and the hilar regions, and the posterior aspect carries the vessels, the esophagus, and our spinal column. So what consists of a normal chest radiograph before we get into some pathology? So this is a normal posterior to anterior chest x-ray, and we're going to be going over the difference between an anterior to posterior film and why we look at this. When we're talking about the film quality, what we're talking about here is rotation, inspiration, and penetration. So we want to know if something's rotated correctly. If it isn't, one lung will appear darker. Those medial clavicles should be equidistant from the vertebral spinous processes. Inspiration, you should be able to see roughly 8 ribs. If it's underexpanded, it's going to look like pulmonary edema. If it's hyperinflated, the heart's going to appear smaller. And we should be able to see the vertebral disc when we're talking about if the film is penetrated correctly. How do we interpret these radiographs? Well, we go through the ABC starting with the airway. The carina should be midline. The bones, we want to look for fractures. You're going to turn the radiograph at about 90 degrees to make it easier. In regard to if there's a normal film, the scapula should be off the lung fields, and we'll see what the difference is between an AP to a PA. In regard to the cardiac silhouette, you want to examine those heart borders. The cardiothoracic ratio should be less than 1/2. Diaphragm should be good, well-defined margins. We'll talk a little bit about the costophrenic angles in a bit. You shouldn't see any free air under the right side. The left side will have a gastric bubble, so there can be lucency in that regard, and that correlates with lower down the side there. Effusion, again, we talked about the costophrenic angles. We're going to check the lung bases, the fields of our bilateral lungs, and we should see the apex above the clavicles when we're talking about the lung fields. Our hilum, the left, is going to be higher than the right. This is where you check for adenopathy, vessel engorgement. When we see the hilar shadows, the vast majority of that is the vessels, more so than the nodes. Looking for different lines that are indwelling. As we look at these and how to differentiate them is by usually their endpoint. Sometimes the thickness of the line. So you have endotracheal tubes, chest tubes, nasogastric tubes, central lines, pacemakers. And then in the end, we want to compare to any other film, similar to with the feet, EKGs. So we're looking at our anatomy. So different things to look at here. So we're looking at our actual heart shadow itself. Okay. Cardiophrenic angles, costophrenic angles, the apexes of our lungs, the peripheries of the lungs, of course the bones, the generalized soft tissue, and then the diaphragm itself. So our left side of the anatomy, we start to look, we see what's called the aortic knuckle, this outpocketing right here. A lot goes on in this region here. You have your aortopulmonary window, your left pulmonary artery, and your hilar point. There's a similar point on the right side of the heart we'll go over. Then you look at your atrium in this region, and your ventricle occupies this whole side. Now the right side here, you have the paratracheal region. Again, here's your hilar point correlating to the right side here. You have your pulmonary artery here. And then this side here correlates with your right atrium. You do not see the right ventricle because it's anterior and superimposed, so it's not readily visible by a border. We talked about the difference between a PA and an AP film. Well, often we get these on inpatients in portable films. The heart can appear larger on an AP, and you'll often see the scapula superimposed posteriorly here. Again, here's the difference comparing the two. A lateral, something that is looked at for specific pathology. Basically, when you're looking at this in regards to either interpretation or to know that the film is produced correctly, you don't want to see the arms overlapping, obviously. The ribs become superimposed, the vertebral bodies are more lucent. The posterior aspect of the heart is the left ventricle. The anterior aspect of the heart is the right ventricle. We have a retrosternal space and a retrocardiac space. So now getting into different pathology that's associated with the chest x-ray. Things that we break down to is the hilum, cardiac system, different type of tumors, bone pathology, what are foreign objects or indwelling lines, and pulmonary pathology. So getting into the hilum, what is the hilum? It's the point of entry on each lung for the bronchus, the vessels, nerves, lymph nodes. A lot happens in this region. Bilateral enlargement can be due to pulmonary hypertension or sarcoidosis. Unilateral usually is suggestive of more of TB or lymphoma. We look at adenopathy. It often gives the smooth lobular appearance. There's possible calcium deposition, normal vasculature leading away. The nodes themselves tend to be more radiodense than the vessels with the loss of concavity, and the vessels are generally traced further distally and they taper off. So here is an example of bilateral hilar lymphadenopathy. This is an example of a unilateral hilar mass. This is another example of bilateral adenopathy. So getting into different cardiac pathology, looking at a pericardial effusion. So this is fluid within the pericardial sac. It will produce more of a globular heart shape, often due to trauma or lung cancer. So it takes quite a bit, as you can see here, of fluid accumulation within the pericardial sac to actually see that change noted on an X-ray. This can be hard to differentiate from global cardiomegaly. Oftentimes you'll see other pathology as well in cardiomegaly. So ventricular aneurysm, well, this is an aneurysmal dilation often due after an MI, post-infarct. It has a focal budge of the heart at a weak point. Often see calcification from that part that has been damaged. Start to see some of that calcific rim here along the ventricle. Left atrial enlargement, you start to see bulging of that atrial appendage. You can get a double right heart border. Many different causes for this, including hypertension, atrial fibrillation, mitral valve dysfunction, or general left ventricle pathology. We can start to see that here. Tumor is very similar to tumors elsewhere in the body. If something is benign, it's usually more smooth, well circumscribed. It can have calcifications within itself. Usually in the lungs, they're located more in the lower fields. Malignancies are usually larger. They're seen higher up in the lung fields, in the hyla or the apex. They can have cavitation on themselves, and they often see lymph node involvement. This would be a benign mass in the right lung field. This is, of course, malignant metastases, unfortunately. So we talked earlier about bone pathology. In relation to a chest x-ray, if you turn it 90 degrees, invert the density, it's easier to see some long bone fractures. We can apply this when we look to metatarsal fractures as well by doing the same on a foot film. Here is an example of a left distal clavicle fracture. So we're looking at foreign objects or indwelling lines. Here we're looking at a pacemaker. These treat heart blocks, symptomatic bradycardia, various heart pathology. Differentiating this from an internal defibrillator treating life-threatening arrhythmias. So the wire tends to be thicker in these. Placement can be slightly different. PICC line, as we're all familiar with, ends in the superior vena cava. The Hickman line, what is this for? This is something we administer with chemotherapy or dialysis. Ends in the vena cava. So a VP shunt, this is something that we see where we're trying to get excess fluid from hydrocephalus out of the central nervous system and into the peritoneal cavity. Talk about the ventricles, we mean the ventricles in the central nervous system. Nasogastric tube. Mitral valve replacement. So when we talk about pulmonary disease terms, we want to look at a few aspects of terminology: reticulation, nodules, consolidation. Reticulation is more to do with linear opacities, so those hyperdense thin lines. We can see it acutely in pulmonary edema, chronically in interstitial lung disease. That's where we get scarring of the alveoli sacs. Nodules, rounded, they're radiodense, and a consolidation is generally a normal area of the lung tissue that's filled with liquid instead of air becomes more radiodense. We do fluid, cellular material, and obviously the most common cause is often pneumonia, what we find. So here's a right middle lobe consolidation. So pulmonary edema, we see this in heart failure. We get the accumulation of fluid in that interstitium along the lines of the airways. These are called Curley's lines. There's different types, A, B, and C, and each of them have a different anatomic meaning. See the different types of Curley's lines here, those linear opacities we see. Again, pulmonary edema, very diffuse. Atelectasis, we see this with the collapse of the lung. We get the deflation of the alveoli, we get cough, we get shortness of breath, elevated respiratory rate. This makes us prone to pneumonia. We'll hear reduced breath sounds on examination. We see this if someone's postoperatively immobilized, they have blockages, or they have different systemic illnesses that can lead to poor surfactant. We're going to see, again, opacification of the lobe and the volume loss. We see a right upper lobe collapse here with the various different lobes and what it appears like. A right lower lobe collapse. You lose the loss of that right base. You lose the outline of that right hemidiaphragm. Middle lobe collapse here, distinguishable here because it's more radiodense right in the middle. Lucency below and above. Left lower lobe collapse, similar to the right side. You're going to see the abnormality with the diaphragm and the angle. And then the left upper lobe collapse here, rather large. You're going to see the elevation of the diaphragm towards it. This here is a complete right lung collapse. You see a mediastinal shift towards the collapse itself. So pneumothorax, we get atelectasis, that's symmetrical loss of the lung markings. We'll actually look and see the defining margin of that on the next slide. This is often due to rib fractures, trauma, penetrating injuries, can be spontaneous, can be seen in chronic illness such as emphysema. When we get a one-way valve, it can be something called a tension pneumothorax. Patients can desaturate from such a thing. We see here on a left pneumothorax, we see our lung marking right here. Look at a tension pneumothorax neck. Here we see a left tension pneumothorax. We see the mediastinal shift and then the lung markings as it's concaving on itself, causing that one-way valve. Pleural effusion, different than pulmonary edema. This is fluid built up in the layers of the tissue that line the outside of the lungs and the inside of the chest, in between. It can reduce the actual chest expansion. You see transitate or exudate. Transitate is bilateral. You see with normal pleura. It can be seen in fluid overload. Exudate is more unilateral. This is something you're going to see with infarction, infection, or malignancy. Here's a right pleural effusion. Fibrosis, this is more that diffuse thickening of the interstitium. You get overlapping thick lines, similar to we talked before about those terminology with reticulation. This is causing stiffening of the alveoli. It can appear as a net-like kind of fine mesh reticulation pattern, sometimes called a honeycombing. So this is lower zone fibrosis, right and left lower lobes, upper lobes here. Moving on to other pathology, we see sarcoidosis. You have that hilar lymphadenopathy. You have the honeycombing from the fibrosis. Emphysema has a very telltale sign here. Everything appears darker due to the reduced size of the vessels. You have what's called barrel-chested flat diaphragm. So what are the surgical implications? How does this pertain to general surgeons and podiatrists alike? So what's the indication for a preoperative chest x-ray? So if someone is being admitted to the hospital, does everybody need a routine chest x-ray on admission? Well, the consensus is usually no, unless there's certain criteria that's needed. Of course, it can be helpful compared to a postoperative film if we're concerned about any cardiopulmonary process. Somebody has acute cardiopulmonary disease based on exam or their history. It's good to obtain that preoperatively. Somebody who has a chronic history of cardiopulmonary disease, someone who's elderly, who has not had a film in the last 6 months, this would be criteria to obtain that upon admission when you know they're going to surgery. How does this affect our perioperative treatment? What can we do to help some of the pathology we just kind of went over, namely atelectasis, pneumonia? Well, incentive spirometer is something we've all heard of and seen. It's also called the sustained maximal inspiration. About 3.5 liters of that total 6-liter lung capacity is due to inspiration. Our average respiratory rate we know is 12 to 20 breaths a minute. So we use this in our postoperative patients that are recovering from anesthesia or if they've had chest trauma. What it does is it inflates the lungs to open up the alveoli, prevent them from collapsing. How this is used and how we explain it to patients, they sit up straight, they exhale normally, and then they inhale with the device. They don't exhale with the device, they inhale with the device. When they're at the max capacity, they remove and they hold their breath. They repeat this several times an hour while they're awake, and afterwards we encourage them to cough to help clear any secretions for it. So it's good for the patients to use this. Oftentimes it sits as a decoration along the bedside, but encouraging a patient to use it, documenting the patient is or is not using it can be helpful postoperatively. These are the sources I used to prepare this presentation. This is my contact information. If you have any questions, please reach out to me. Otherwise, thank you very much for listening today.